let's continue where we left off last time. So last time we were talking about dementia and the difference between dementia and acute delirium. So delirium, quick, right? It's going to happen acutely, it's rapid, and it can be due to a number of things. It could be due to an infection. Right? You could have an infection and become delirious, especially if you have a really high fever. If you have a high enough fever, you can start hallucinating stuff, right? So that would be an example of infection causing delirium. Drugs are going to be really common for delirium. Any sort of deficiency of vitamins can cause delirium. Stress. So the big thing to keep in mind is that it's fast, it's acute, and it's going to be transient. Eventually the person is going to get over it. They're not going to be delirious anymore. Versus dementia, you don't come back from that. Once you start getting dementia, that's it. It's going to keep on progressing. So dementia, the main one that causes dementia is going to be Alzheimer's. It's by far the most common cause of dementia. And then we're going to talk about Huntington's as well as Parkinson's disease and Lewy body dementia as well. But Alzheimer's is by far going to be the most common. Not a normal part of aging, right? So it's not like senile, just having a senile moment, right? So not normal, and then it's going to progress. Dementias progress over time. They get worse and worse and worse. Once you start getting it, once you start getting symptoms, you're not going to go back. You can potentially alleviate the severity of the symptoms. So I think I mentioned to you all when I went to the Alzheimer's Consortium earlier this semester at ASU, there was a physician there that works with Alzheimer's patients, and his big thing was trying to bring the blood pressure down in his patient population. And if he was able to bring their blood pressure down significantly, that actually made the symptoms a lot better. So there's a vascular component to Alzheimer's. Don't really know the exact mechanism behind all that, but there's a vascular component. And so if you bring down the patient's blood pressure, you could help control the symptoms a bit. But other than that, there's like some drugs that you can use to help with some of the symptoms. But broadly speaking, over time, it's going to get worse and worse and worse. So you get failure of higher executive function, confusion, memory loss, all of that. And you can see on MRI or CT scan, you can see the changes to the brain. You're going to see widening of the sulci, you're going to see narrowing of the gyri. So you're having global atrophy of the brain. So the atrophy would not be what you would see in a normal aging brain. It would be much more significant. So what's going on with Alzheimer's disease? Alzheimer's disease is progressive, right? So progressive neurodegeneration. Progressive meaning it's not going to go back, right? It keeps on getting worse and worse and worse and worse. We're going to talk about that with all these other disorders. Parkinson's, Huntington's, Lewy body dementia, they're all progressive neurodegenerative disorders. Eventually, it's going to eventually lead to the person dying, right? Coma and death is going to be the end result. What's going on with Alzheimer's? Age. So the older you get, the more likely you are to get Alzheimer's. There is a genetic component to Alzheimer's as well. The most significant one is going to be this guy right here, apoprotein A. So apoprotein A is the most common genetic disorder that underlines Alzheimer's. Beta amyloid plaques, that's what accumulates in the brain that causes the Alzheimer's. So you're going to get two things, beta amyloid plaques and neurofibrillary tangles. Those are misfolded proteins. So what happens when you're going to sleep at night? Actually, what happens throughout the day when you're like undergoing normal cognitive function throughout the day? Over the day, you're going to have accumulation of misfolded proteins. And that's normal, right? But at nighttime, when you're in REM sleep, that's when your little microglial cells go into your brain and help to start removing all the accumulated debris from throughout the day. So, in other words, people who have really poor sleep, and that happens as you get older. The older you get, the more you see insomnia. Right? It's very common for older people to have to take trazodone and drugs like that to help them fall asleep. As you progress throughout your life and not get enough sleep, you're going to start getting an overaccumulation of those misfolded proteins. So that's one of the underlying mechanisms. So sleep is really important. Generally speaking, you want to get about 8 hours of sleep, right? That's kind of like a sweet spot. 7 hours you can get away with. 6 hours, you're cutting it. Anything below 6 hours of sleep is bad. So for every hour below 6, for every hour that you miss a sleep, it's equivalent to 1 alcoholic drink. So if you get 5 hours of sleep, it's like you drank 1 glass of beer, right? If you got 4 hours of sleep, it's like having 2 drinks. 3 hours of sleep, it's like having 3 drinks. 2 hours of sleep, it's like having 4 drinks. So it's basically going to be very similar to alcohol intoxication. So you want to have good amounts of sleep so you can function the next day, and because you want to avoid things like Alzheimer's. Parkinson also. Parkinsonism is going to be, there's a link between poor sleep throughout one's life and developing Parkinsonism. So you had a question? There's a study for that, and I don't have it out. I don't remember who did it. Dangerous. It's so dangerous. And there are studies that talk about this. You couldn't. I'll try to find it. I'll try to see if I can find the study that talks about that. Yeah, it's really important. And on top of that, driving when you're sleep deprived is actually more dangerous than driving drunk. The reason being is because when you fall asleep at the wheel, that's it. You lose consciousness and you're asleep at the wheel. Versus if you're drunk at the wheel, at least you're conscious. You're not like super conscious, but you're at least conscious and kind of awake. So dangerous. So dangerous. There's actually, I was reading a really sad story on a doctor, resident doctor, who was working horrible hours, and I think it was a female. She was driving home after like several crappy shifts, and she fell asleep at the wheel and died. So it happens. People fall asleep at the wheel. Drunk driving is also bad too, so I'm not recommending drunk driving. But if you were to do one or the other, it's at least safer to not be sleep deprived. You want to have full sleep if you're going to be operating something as dangerous as a car, right? Driving 70 miles an hour on the freeway, and then all of a sudden you fall asleep. That's not a good situation. Presenilin is another thing that you'll see accumulating in Alzheimer's disease. So chromosome 21, so think about trisomy 21. If you have Down syndrome, there's genes on chromosome 21 that can predispose a person to getting Alzheimer's. If you have trisomy 21, then you're even more predisposed to getting Alzheimer's. So Down syndrome individuals are going to have a higher propensity for Alzheimer's. Low education, but it's not even just low education. It's like not stimulating your brain throughout your life. One of the best ways to stave off neurodegenerative diseases is to learn new things all the time. Be a lifelong student. Learn new skills, learn new languages, learn an instrument, learn anything that's going to help to stimulate your brain, even until your older years. Because the more stimulation you have cognitively, the more you are going to protect yourself against any neurodegenerative disease. So use it or lose it. Use your brain. So that's why it says low education, but it's not low education per se. It's the lack of learning new skills, right? So this is what's going on with the pathophysiology on Alzheimer's. The main thing that happens with Alzheimer's is brain atrophy. So if you were to look at a radiograph, you're going to see widening of the sulci. Those are the little ridges, right? No, not ridges. They're like the troughs, right? The troughs in the brain, right? So sulci, you're going to see widening of the sulci, and you're going to be seeing narrowing of the ridges, which are the gyri. That's like the peaks of the valleys, right? And so atrophy is going to be the major thing. And what do the ventricles look like when the brain atrophies? The brain is atrophying, so now the ventricles are just going to look like they're dilating. Their ventricles look bigger than they usually are. And those are all just going to be filled with CSF, so nothing crazy there. Beta amyloid plaques, that's one of the hallmarks of Alzheimer's, an accumulation of beta amyloids that's going to disrupt action potentials. And then neurofibrillary tangles are the other hallmark of Alzheimer's, and that causes the neurons to actually die. What is going on in terms of neurotransmitters? Acetylcholine levels are going to drop over time. And so you can actually treat Alzheimer's with acetylcholinesterase inhibitors, so you prevent the degradation of acetylcholine, so it helps to increase the amount of acetylcholine in the patient. Does it cure it? Does it cure Alzheimer's? It doesn't, but it helps to minimize the symptoms of Alzheimer's. You have a question? Huh. I have to look into that. Yeah. I mean, there's ongoing research in neurodegenerative diseases, so they're always finding new things. If you could find that study or a study that it's like, is it the chicken or the egg, right? Which one comes first, right? So I don't know. I don't know the mechanism, but all I know is that these are the hallmarks of Alzheimer's: beta amyloid plaques and neurofibrillary tangles. If you find any studies that talk about like what comes first, I would be really curious to read about it, and I'll include it in my future lectures. So acetylcholine, that's the major neurotransmitter involved in Alzheimer's. Prevention, try to be healthy, right? So have control of blood pressure, right? Blood pressure control really helps to stave off Alzheimer's. Be intellectually stimulated as much as you possibly can throughout the duration of your life. Like I said, learn new things, read books, develop new skills. All that is really good and important. Plus, it's fun, right? You learn new stuff, like learn how to play an instrument, something like that is going to be cognitively challenging. And then social activity is also good. So what are the A's of Alzheimer's? These are all the major A's. The main one, and the first one to happen, is amnesia. So you start losing memory. And there's two different types of amnesia. There's going to be anterograde amnesia, and there's going to be retrograde amnesia. The first one to go is going to be your anterograde memory. So what does that mean? It means that the things that you had just learned, the things that you had just heard from someone, the things that you just recently been exposed to, you're going to forget it. So that's anterograde amnesia. You can test that on a mini mental status exam by when you do the exam on a patient, you could say, all right, I'm going to say 3 words. I want you to remember these 3 words in the next 10 minutes. So you'll tell them, remember triangle, sun, tree, right? And then you'll go on with the exam. So you have them do a bunch of other tasks. And then like 10 minutes later, if you don't forget to ask them again, because I've done that a lot, I'm like, oh, damn, I forgot to ask them to remember those questions. So if you remember 10 minutes later, ask them like, oh, do you remember those 3 words that I had you recite? And then if they can remember those words, that's a good sign, right? That means they don't have anterograde memory loss. If they forget all 3 of those words, that's bad, right? That means that the person has pretty bad anterograde memory. Retrograde memory is different. That is like recollecting things from way in the past, right? Maybe childhood friends, maybe formative memories, places you've lived, your family members, right? A lot of times, advanced amnesia, what happens? You start to forget who you are, right? It could be your parent, it could be your brother, it could be a sibling, it could be anyone. But they start forgetting who you are. That's really advanced stage Alzheimer's. That means that they do not have any more recollection of their retrograde memory. So the retrograde memory loss usually happens later on. Anterograde happens first. Retrograde happens when you're at the advanced stages. Anomia means you do not know the names of the objects. So if you had, during the mental exam, you hold up your pen, you're like, tell me what this is. And then they'll be like, oh, that's a pen. It's great. Sometimes they might not be able to tell you what that is. Right? There's actually a book by Oliver Sacks, and it's about the husband, the woman who mistook her husband for an umbrella or something like that. It was about a lady, I think that's what the title of the book, but it was Oliver Sacks, who was like a really famous neurologist, really great writer too. He wrote a lot of really wonderful books. But there was a book that he wrote about a lady that I think forgot what her husband was, right? And so you can get like defects of perception with anomia, so you can't name an object. Apraxia. Praxia means being able to do something, right? So if you have apraxia, that means you're losing the ability to do stuff. And you can test apraxia. One of the things you can do on a mini mental status exam is you have them drawing 2 pentagons that intersect at 2 of the sides. So if you were to draw that, you would have to give them the pen, right, so that they'd be able to actually draw that. And so what you're doing is you're going to, let's see if I can get a pen up in here. So you have them draw 2 pentagons, and then have them intersect at 2 sides. Right, so it's intersecting here, and it's intersecting here. So that's one thing that you can do to test to see if they have something like apraxia. If they have apraxia and they're not able to manipulate the pen properly and draw an image that you ask them to draw, then that would be one of the symptoms of Alzheimer's or any other like neurodegenerative disorder. Agnosia is inability to identify objects, versus anomnia is naming, right? You don't know how to name an object. If you can't recognize an object, that's agnosia. And then aphasia, we talked about the different types of aphasias. That's difficulty in speaking. Behavioral symptoms. You get mood swings. Have you ever heard about sundowning? Sundowning. So as the day progresses, patients that have Alzheimer's and dementia, towards the end of the day, they start getting very agitated. This has been happening with my father lately. He's old at night. He doesn't get aggressive. He's actually a more jolly person by nature. But some people are not as jolly. When they start getting mood changes towards the night, sometimes they stay awake at night and they get really, really agitated, angry, combative. So you'll see that with a lot of Alzheimer's patients. And then they'll have insomnia, right? That's actually what's going on with my dad. He gets his sundowning. He gets very talkative. He talks all sorts of weird stuff. His caretakers tell me that, you know, some of the stories he says are ridiculous and hilarious. He just talks a lot of nonsense, and that's part of his sundowning. And then other things that you'll see, depression and confusion, right? Depression is very common in Alzheimer's patients, right? So obviously they're losing their faculties and capacities, cognitively speaking, and so they're going to get super depressed because of that. And then your ADLs and your IADLs, right? So your activities of daily living are going to be lost with Alzheimer's. They don't. Yeah. It could also be because parts of the brain are just being atrophied, and that could cause depression too. So it could be organic, but it could also just be because like they're older, they are not able to do the things that they used to do. They're losing their memory, so all those things can make them agitated and depressed. But it could also involve just the sheer atrophy of the brain. It could be affecting like, you know, regions that produce like serotonin, for example. Right, so like the locus coeruleus could be involved in that. That's the area that produces serotonin in the brain. So I could imagine that's affecting everything. And that's why you're getting depression. Does that make sense? I love this picture. It's so funny. I always thought it was old timers disease. Anyone here thought that when you were a kid? I always thought it was old timers disease. So mental status exam. This is what you can do with the mental status exam. So let's take a look at the mental status exam. Mental status exam is actually really fun. I always enjoyed doing mental status exams on patients because they're interesting. So you've asked them basic questions, right? What's the year? God, when my dad got diagnosed with Alzheimer's, he said it was like year 2020, like 2020, like I don't know, something crazy. Like it was like 200 years in the future or something. And he didn't remember the president, right? So like these are the questions that you ask somebody when you're diagnosing with dementia. Who's the president? What year are we in? What's the day? What's the month? What season are we in? Those are just basic things that most people should know. But if you don't have the ability to recollect those things, that's one notch off the score. Where are we currently? You know, some people won't even know where they're at. Like they're in the hospital, but they won't even know that they're in the hospital. Name 3 objects. And then counting backwards. This is the one I always hated because I can't even do that. Counting backwards in sevens. So you go from 100 to 93, and I'm just like, all right, you got me there. I don't know anymore. So I was never good at that anyways. But you can have people spell words backwards too to see if they can like spell the world backwards. And then the 3 things, right? So you have them remember 3 things, and then you later on ask them what those 3 things were. So that test for their anterior grade memory. Repeating phrases that are tongue twisters, right? So Peter Piper, pickle pepper, I don't know the whole thing, but no ifs, ands, or buts. You can have them repeat phrases, and if they can't do it, that would be indicative of like aphasia. Have them do instructional tasks. So have them take a piece of paper, fold it in half, put it down. Here's that intersecting pentagons. You have them intersect at 2 different points. Yeah, so those are all different things you can do. And then you can see the severity of their their loss of function, right? So you could see anything that's abnormal would be under 24. Yeah, sorry. Severe would be less than 10. Uh, Mild would be less than 25. Moderate is 10 to 20. So that you give a numerical value for all these scores, right? So you give a score of like, if they could name two of the objects, you would give them like a reduced score, like a partial score. Right? If they couldn't remember any of the objects, then that would be like a more severe type of anterograde amnesia. So that's the mini mental status exam. Pretty fun. Maybe you could administer that to your friends and family and see if any of your friends and family have dementia. Do that over Thanksgiving break, right? Like, come on, Grandma, I think you might have Alzheimer's. Complications. Over time, it's going to eventually lead to death, right? So one of the things that you see, they're unable to do things, right? So they're also going to be unable to swallow properly. So aspiration pneumonia is going to be a common cause of death for these patients. Falls, right? When a person falls and they're elderly and they break something like a hip, that's sometimes a death sentence because then they're going to go to the hospital. When they go to the hospital, they're old, so they're immunocompromised. They could get pneumonia just by being in the hospital, right? And so those are all the things that you see with these patients. These are terrible. Decubitus ulcers, bed sores. Yeah, when a patient's bedridden, you have to move them every 4 hours. So if a person stays on their back for too long, especially at the sacral area, they start developing ulcers in their skin, right? Because the pressure from the bed, even though the bed is soft, the pressure is going to start interfering with circulation, and so those patients are going to start getting bed sores. So not a good situation. So you want to rotate them every 4 hours, have them prop up with pillows and things like that. What's up? They would be confused. They would be super confused. They would be even more agitated. Yeah, they would be feeling pain, right? But they wouldn't really know how to express it properly, right? So advanced stage Alzheimer's, especially if you're bedridden, like your ability to communicate will be massively impacted by that. Yeah, and then malnutrition, dehydration. They're not able to take care of themselves. It's like activity of daily living are being affected, right? So they're not going to be drinking fluids. A very common theme for older patients, UTIs, right? But also getting dehydrated and having electrolyte imbalances. Those are all things you'll see in like nursing homes, and especially if the people aren't being cared for properly, which unfortunately is a very common theme in nursing homes. Elderly abuse is very common. Elderly abuse and elderly neglect. Sometimes caretakers get lazy and they don't care, or at worst, maybe they're malevolent and they actually want to harm their patients by neglecting them. So those are all really sad realities of geriatric medicine. So this is another schematic of all that. So anomia, not able to name things. Apraxia, not being able to do things like manipulate tools or instruments. Agnosia, forgetting what things are. Amnesia, memory loss, and then aphasia, and inability to speak properly. And here's another breakdown of those things that are happening at the organic level. So you have neurofibrillary tangles and beta amyloid plaque accumulation, the hallmarks of Alzheimer's disease. And then this is what the brain looks like when it's atrophied. So here's a normal brain. You see the ventricles look pretty good. You got normal sulci and gyri over here. Sulci, massive. Gyri, a little atrophied. Here, ventricle, massive, right? It's huge ventricles. That's because the brain is just atrophying significantly. And then here's another image of what the brain might look like on a radiographic scan. So this is an MRI, and you can see normal brain. It looks really good. The ventricles are normal sized. The subarachnoid space, you get a little bit of space there for the CSF. But when you have atrophy of the brain, ventricles are huge, and then it's just shrinking, right? So the subarachnoid space is going to look a lot larger than normal. And then if you were to do a radionucleotide type test, you would see These are with like glucose type test. It's like a radioisotope of glucose, and you can see which parts of the brain are lighting up on those types of scans. And if you see reduction in activity like this right here, that could also be indicative of Alzheimer's. Alzheimer's vaccine, there's been some studies done to try to develop some sort of Alzheimer's vaccine. I put, this is an older link from 2018. This is more recent. And so they're trying to develop something that might be able to help prevent Alzheimer's. To my knowledge, there's really nothing available yet on market, but they're all being developed. But this is a really good image right here. You can see how the gyri look really thin compared to normal, and then the sulci also look very wide compared to normal. All right, any questions on Alzheimer's? Yeah, you can give them acetylcholinesterase inhibitors. I can't remember the names of the drugs off the top of my head, but you can give them drugs to, so one of the things that you see is reduction in acetylcholine release. And so acetylcholinesterase is what breaks down acetylcholine. If you do an acetylcholinesterase inhibitor, you're inhibiting the enzyme that breaks down acetylcholine. So you're going to have more acetylcholine available. And so it doesn't cure Alzheimer's, but it can help to mitigate the effects of Alzheimer's. They're not the greatest drugs on earth, right? You're basically just slowing down the inevitable. This is really sad, Lewy body dementia. We're going to talk about Robin Williams a couple times because he also had bipolar. But I always thought that he killed himself because of bipolar. Because when you have bipolar depression, you're at really high risk of suicide. So patients with bipolar often harm themselves, and they also harm others too, because they tend to be, when they're manic, when they have their manic episodes, they can be violent. And then they'll inflict harm on themselves too. I thought that's what killed Robin Williams. But it actually turns out that Robin Williams was really losing it towards the end because he was misdiagnosed. They didn't know that he had Lewy body dementia until it was basically too late. This article that I included, that's written by his wife. It was published after he passed away, and it's a really sad article. But yeah, I was talking about how he was losing his mind. He was aware of it. Robin was growing weary. The Parkinsonian mask was ever present. So Lewy body dementia looks like Parkinsonism and Alzheimer's. So you're going to have both of those things happening with Lewy body dementia. He had the shuffling gait. That's going to be due to Parkinsonism. He had the tremor. He hated that he couldn't find the words that he wanted. So that would be also kind of what you'd see Alzheimer's type effects. He would thrash at night. He had insomnia, find himself stuck, frozen in a stance, unable to move, frustrated. He was beginning to have trouble with visual and spatial abilities. Yeah, then he lost, his loss of basic reasoning just added to growing confusion. He was also having hallucinations. So terrible stuff happening to him. So that's one of the reasons why he eventually committed suicide. So really, really tragic situation for Robin Williams and anybody who suffers from Lewy body dementia. So Lewy body dementia, you get both things happening. You have dopamine and acetylcholine is being markedly reduced. So with dopamine, it's going to look like Parkinsonism. So you have the flat affect of the face, shuffling gait, difficulty initiating movement. And then with the reduction of the acetylcholine, that's where you have memory loss. So it looks like Parkinsonism plus Alzheimer's. So it's a really terrible double whammy. Alpha-synuclein accumulation. Alpha-synuclein is also the hallmark of Parkinson's too. So they're very similar. Similar type of diseases when it comes to the mechanism or the pathophysiology of the disease. Lewy bodies are filled with alpha-synuclein accumulation. And alpha-synuclein is basically just misfolded junk proteins. It's going to be a small percentage of all the cases, because remember, Alzheimer's is like by far the most common one, right? But Lewy body dementia is going to be a smaller percentage of cases. So because of that, some people think it's Alzheimer's, so they misdiagnose it. Robin Williams was misdiagnosed. His caretakers didn't know that he had Lewy body dementia. So that's, and even if they were able to diagnose it properly, not really much that they can do about it anyways. because these diseases, you're just treating the symptoms and you're staving off the inevitable. You can give them acetylcholinesterase inhibitors. You can give them dopamine drugs. So you can give them levodopa, carbidopa. Over time, it's really not going to have much effect. You have like a window period where it helps, but then the severity of the disease gets to a point where the drugs don't even help. Older patients, right? This one is going to happen to more males versus females. I have over here Alzheimer's. Did not put it there. Never mind. Yeah, forget about it. Just know Lewy body dementia happens with more men than women. Chief complaint of these individuals, it's usually from their spouses or relatives and loved ones, that they have personality changes. The personality changes are going to be some of the major things. I mean, you're going to see personality changes in the other ones too, but Lewy body dementia, you'll see hallucinations, personality changes, all that stuff. Watch a little video on Lewy body dementia.
Lewy body dementia took over the life of the man who got to meet. The disease is the second most common form of dementia, Alzheimer's being the first. There is no cure, but experts at Mayo Clinic are researching Lewy body disease in hopes of improving the lives of people who struggle with it. In hindsight, though, there were things going on before, but I'll be there one day. But the little changes Marjorie Zellers noticed in her husband Richard were early signs of Lewy body dementia. Freshmen were almost not there anymore. Richard also developed Parkinsonism, which often accompanies the diagnosis of Lewy body dementia. Difference in walking, gait, their lives have also changed. He was a boater, tennis player, racquetball player. Richard is not independent anymore. His symptoms are slowly getting worse. Months ago, I just kept go back. I kept wanting it to be like it was. Long time ago. In moments of clarity, Richard describes what it's like to slowly. It's like someone you wrote all your information. That's right. Problem. And improving on it is what Dr. Tanis Furman and Dr. Dennis Dixon strive to do. We try very hard to detect and diagnose as early as possible. Our goal is to try to we can increase the person's level of function at a higher level early on. Dr. Furman says it's key to make sure the diagnosis is correct. You see, Lewy body disease is often misdiagnosed as Alzheimer's disease. The two may respond differently to some medications. Because there is no cure, the disease will inevitably progress. Dr. Dixon is researching what Lewy body disease does to the brain. So the idea is to find what the other things that diagnose it after. Also, if we study the those might lead to the hope of new treatments to improve the lives of people like Richard Zellers. In addition to making sure the diagnosis is accurate so people can get on proper medications, Dr. Furman says it's also important to help patients and their caregivers get the support they need at home. That can ensure a better quality of life for patients and their loved ones. From Neurology, I'm Neurology.
So I wanted to verify the gender thing because Alzheimer's affects women more than men. I didn't know the ratio off the top of my head, so I looked it up. Women are twice as likely to develop Alzheimer's compared to men. So that's going to be different than this one right here, right? So Lewy body dementia is going to be more common in men than females. So there is a gender difference for these disorders. Family history and brain injuries will predispose an individual to Lewy body dementia. The biggest things you're going to see is changes in behavior, hallucinations, impaired thinking, Parkinsonism, right? So you get the slow movements, difficulty initiating the movement, shuffling gait, tremors, all that stuff you'll see with Lewy body dementia. How do you diagnose it? You can diagnose it with just the family, the HPI, so it's the history of present illness. So the patient or the relatives will start telling you, a little bit more about what's going on with the relative, and so they'll give you some hints and clues as to what might be the disease. You can do MRI scans just to rule out other type of things that could be happening, maybe like tumor, because tumors can potentially cause symptoms that look like dementia. Right? So you want to rule out other organic underlying causes. How do you treat it? You don't cure it. You can treat it symptomatically. So as I mentioned, Alzheimer's, you can give the same type of drug here, acetylcholine esterase inhibitors. So it prevents the breakdown of acetylcholine. So you can use that. Carbidopa, levodopa, that's going to be how you treat Parkinsonism. Are they great drugs? Not really, because they're not really going to help cure, right? The person's still going to eventually degenerate. It slows the process down. So it slows the degeneration, but you're not going to cure it. And for Lewy body dementia, they have a few years to live, basically.
Here's why. In Alzheimer's disease, many of your brain cells or neurons die. In Lewy body disease, some neurons die, but many are still alive. They're just not working properly. Certain medications called cholinesterase inhibitors help trigger nerve impulses from one brain cell to the next.
All right. Close out of these. Cool. So any questions on Alzheimer's or Lewy body dementia? I have no idea. I don't know. Yeah, he was a heavy drug user. Yeah, for sure. I mean, drug use over time can definitely, you're screwing with your brain chemistry. So is it predictable how you're going to screw with your brain chemistry? It's not, but it would be a predisposing factor for sure. Oh yeah, he was extremely bright. Right. There's got to be something going on there genetically, but also maybe all the drug use, heavy drug use can definitely cause all sorts of issues with brain chemistry. I think for him it was like specifically cocaine. I think it was mostly cocaine, and cocaine works by blocking the reuptake of dopamine. So dopamine stays at the synaptic cleft for a longer period of time. And so that could probably alter dopaminergic pathways. And there's a dopaminergic pathways are associated with Parkinson's. So who knows? Could all be stemming from drug use, but also maybe family history. Who knows? And a lot of these things are really, there's research, ongoing research, but still the mechanisms are still poorly understood. Yeah, melatonin can help with Alzheimer's. The question was if a person has insomnia, can they take melatonin? Yes. Does melatonin work great? No. So they can take melatonin, but it's really not going to help that much. Usually they want to take something more like trazodone is a better drug. Even trazodone doesn't really help. Like if people have like really bad insomnia or advanced stage dementia, even drugs like trazodone will not really help too much. So kind of sucky, right? It sucks. Getting old sucks, right? Lots of us are going to probably have a similar fate when we're, in our golden years. So let's switch gears now. Let's talk now about Parkinson's versus Huntington's. So these are going to be lumped together because they're movement disorders. With Parkinson's, you have little movement. So yeah, you have less movement. Whereas with Huntington's, you have more movement. So different regions of the dopaminergic pathway or different parts of the dopaminergic pathway are going to be affected differently by Parkinson's versus Huntington's. So with Huntington's, one of the things that you'll see is chorea. Chorea is where you have really weird. Chorea means dance, and so a person with Huntington's is going to have this weird like type of dancing thing where they just constantly are dancing and moving. Whereas with Parkinsonism, you're going to have reduction in movement, right? So you're going to have flat affect. Your face is just going to look really. It's like you're wearing a mask, right? You're going to have a difficult time initiating movement. Like you're going to have a hard time beginning to walk. You're going to have a hard time moving your arms, moving your hands. So it's like a difficult time initiating movement. Whereas with Huntington's, it's the opposite. Like you're moving way too much. So what's going on with movement disorders like Huntington's and Parkinson's? They're basically going to involve a region of the brain called the basal ganglia. And the basal ganglia is really important for regulating movements. It's also really important for cognitive function as well. And it's also going to be important for emotional processing and emotional regulation. So the different regions that we're going to talk about involve striatum, globus pallidus, the subthalamic nucleus, and then the substantia nigra. Parkinson's is really going to affect the substantia nigra, specifically the substantia nigra pars compacta. And that's going to be the region of the brain that actually produces dopamine. If you wipe out the region that produces dopamine, you're not going to be able to have a functioning dopaminergic system, right? And that's going to affect the basal ganglia. The striatum, that's going to be receiving input from the cortex. So when the cortex wants to do something like initiate movement, it's going to signal to the striatum to do a movement of some sort. The globus pallidus is going to be involved in inhibiting movement. It's always going to inhibit. So if you inhibit the globus pallidus, that's when you actually get movement. But if the globus pallidus remains intact and doesn't do anything, like you don't inhibit it, then it's going to just constantly inhibit movements. And then the subthalamic nucleus is going to be important in the regulation of those movements. What's up? So both are going to affect the substantia nigra. We'll talk about that in a little bit when we do a comparison and contrasting Parkinson's from Huntington's. So the basal ganglia effectively is going to be really important for posture and movement coordination. So we're not going to really talk about the emotional regulation of the basal ganglia because we're going to mostly focus on the actual movement disorder and what's the pathophysiology behind the movement disorder itself. So here is what's going on with when you initiate a thought that is with the ultimate goal of moving. So you have an idea, so you're going to have the cortical associated areas that are going to be involved in the idea. And so you start to plan the movement, and it's going to involve the cortical association area. It's going to also involve the basal nuclei, or the basal ganglia, and it's also going to involve the cerebellum. Because remember, the cerebellum is really important in movement and for posture as well. So if you wipe out the cerebellum, you're going to have a weird, unsteady gait. You're going to walk funny. You're not going to be able to, do like a fingertip to nose type of thing. You're going to have a really hard time coordinating those types of movements. So the cerebellum is going to be involved in here too. And then you have the motor cortex. So in order for the idea to allow for the motor cortex to be initiated, you have to affect the basal ganglia. The basal ganglia is going to regulate the ability for the motor cortex to actually be able to do its job and initiate movement. Once everything is in place, then the idea will translate to the actual movement itself. If you have Parkinsonism, you're going to have a difficult time initiating movement. If you have Huntington's, you have a difficult time regulating movement. So you're going to have unregulated movement. So it's hyperkinetic. And then if you have any issue within the basal ganglia, that's going to be referred to as extrapyramidal symptoms. Extrapyramidal symptoms means that you have a movement issue. These are all extrapyramidal type symptoms, right? Difficulty time initiating movement, difficulty controlling movement. So Huntington's, Parkinson's, those are extrapyramidal. And drugs can cause this too. So antipsychotics are notorious for causing extrapyramidal side effects. So especially the traditional antipsychotics. So drugs like Thorazine, which is one of the OG antipsychotics. Drugs like haloperidol, commonly used antipsychotic, but has a higher chance of causing extrapyramidal side effects. So have you heard of someone having a shuffling gait when they take like Thorazine or haloperidol or one of those antipsychotics? That means that they're having a really hard time walking. So they start shuffling around. They'll kind of be stooped over, staring at the ground, shuffle. Their arms will be like kind of stuck to their sides. That's a shuffling gait. They used to call that the Thorazine shuffle. So not a good situation. So those old traditional antipsychotics, those drugs sucked because it would be like the side effects, like, yeah, maybe you're helping with the patient's schizophrenia, but now they're going to have extrapyramidal side effects. They're going to have Parkinsonism as a consequence. So pretty bad. You can also see like tardive dyskinesia, which is where you're like sticking your tongue out. Uncontrollable sticking your tongue out, lip smacking. That's tardive dyskinesia. I've seen lots of people with that. So especially people like older people who have schizophrenia and they've been treated for like since like the 60s and 70s with antipsychotics, those patients are going to have lots of tardive dyskinesia and other movement disorders because those traditional antipsychotics were really bad. There's other drugs now, like the second generation antipsychotics are a lot better. But yeah, schizophrenia sucks. We're going to talk about schizophrenia on the last section of neuro. So anyways, let's talk about the direct versus the indirect pathway. The direct pathway is going to be what's associated with allowing the initiation of movement, whereas the indirect pathway is going to help control and mitigate movement. So let's talk first about the direct pathway. So the substantia nigra is what, as I mentioned earlier, produces dopamine. So you need the substantia nigra to actually produce the dopamine that your brain needs for this whole entire movement pathway to take place. So D1 pathway is the direct pathway. So when you produce dopamine, it's going to be sent to the striatum. The striatum is kind of like what's holding on to the dopamine. And then the striatum is what's going to respond to the motor cortex. So when you have the motor cortex and you have a thought, and the thought says, oh, I want to move my arm, or the thought is like, oh, I want to walk in whatever direction, that's going to begin at the cerebral cortex. Then that is going to send positive neurostimulants to the striatum. Glutamate is going to be the main neurotransmitter involved in that. And when the striatum is initiated, it's going to block the globus pallidus from operating. The globus pallidus is a perpetual off switch. So the globus pallidus is going to stop everything else from working. So it is going to be always sending inhibitory signals to everything else. If you turn the off switch off, then you can turn things on, right? And so what the striatum is doing, it's sending GABA, which is a neurodepressant. If you're sending GABA to the globus pallidus, you're going to be suppressing the globus pallidus. So you're going to be suppressing the suppressor, right? And so when you suppress the suppressor, then you can actually get movement to be initiated. It's going to send signals to the thalamus. The thalamus is kind of like the relaying point for all sorts of different tracts. When the thalamus can get turned on, that's going to send glutamate, which is going to be a neurostimulator, to the motor cortex. So now you can initiate movement. That's everything that's going on when you actually do any sort of movement. Super complex system and network of signals sent around the brain and the basal ganglia. What's up? The globus pallidus, assume that the globus pallidus is always on to suppress things from happening. And so in order to initiate movement, you have to basically turn the globus pallidus off, right? So you have to suppress the suppressor in order for you to initiate movement at all. So this whole pathway, the direct pathway, is supposed to be initiating movement. So this stimulates things to happen. The indirect pathway is the opposite. It's going to stop movement. So it's inhibitory, whereas the direct pathway is, think of it as being like excitatory. So again, substantia nigra is what produces dopamine. It gets sent to the striatum, but this is going to be part of the D2 pathway. So the D2 pathway is indirect. So if you want to initiate some sort of thing to happen from your brain, or sorry, from your cerebral cortex, it's going to send glutamate to the striatum. And if the D2 pathway gets turned, if the D2 pathway gets initiated, it's actually going to send signals to the globus pallidus externus, which is a different set of the globus pallidus. And the globus pallidus externus is what helps prevent movement from taking place. And then if you turn off the subthalamic nucleus, that's going to, this is like super convoluted. It's hard to explain. Let me try to start from the beginning here. So substantia nigra, producing dopamine, gets sent to the striatum. That's a D2 pathway. If the D2 pathway, which is inhibitory, now inhibits the globus pallidus externus, you're going to reduce activation of the subthalamic nucleus. That is going to thereby increase glutamate to the globus pallidus internus. That's going to inhibit the thalamus. That's going to reduce glutamate to the motor cortex, and that's going to stop movement altogether. Right? So the ultimate goal of the indirect pathway is to stop movement, is to reduce motor activation. Okay? So just kind of understand like the general gist of the direct versus indirect pathway. If you're comfortable with the fact that direct pathway initiates movement, whereas the indirect pathway inhibits movement, then you should be good. So don't get too bogged down with all the neurotransmitters involved in this process. This just gives you a good overall depiction of all the different types of neurotransmitters that are involved. GABA, glutamate, dopamine, etc. So Parkinson's disease down here versus Huntington's disease. Parkinson's disease, you have not enough direct pathway taking place. So you're wiping out the direct pathway. The indirect pathway is going to have more, is going to be more involved. So in other words, you're going to see more inhibition of movement. Huntington's, you're going to see more direct pathway, and you're going to see more movement, increased movement, abnormal movement. So it's going to be hyperkinetic. So what's going on with Parkinson's? You're wiping out the substantia nigra. You're not able to produce dopamine. If you can't produce dopamine, then your striatum isn't able to do its thing. So in other words, the striatum will not be able to send signals to the globus pallidus internus. So you're not going to allow the inhibition of the inhibitor, right? And so in other words, you're constantly inhibiting movement if you're not turning that section of the brain off. So you're going to get hypokinesis, so you're going to get reduced movement with destruction of the dopaminergic system. None of this stuff is going to be happening. You're not going to get the initiation of movement. And with Huntington's, it's going to be the opposite. So what's going on with Parkinson's? To recap, you're going to have under normal circumstances, D1 is going to stimulate movement, D2 inhibits movement. If you have Parkinson's disease, you're wiping out dopaminergic production. So the substantia nigra cannot produce dopamine, so you're going to have a defect in the initiation of movement. Here's another depiction of what that looks like. So you're not getting any dopamine produced whatsoever, and you're going to have a difficult time initiating movement. Huntington's disease is going to be hyperkinesis, so hyperkinetic. So you're going to be seeing more of the direct pathway, and you're not going to see enough of the indirect pathway. So the D1 pathway is going to be exaggerated in Huntington's. The D2 pathway is going to be wiped out. So if you wipe out that D2 pathway or the indirect pathway, then you're going to have way too much D1 pathway, way too much initiation of movement as a consequence. So, extrapyramidal symptoms. These are what these all look like. So you get the shuffling gait. The posture is going to be a little stooped. You're going to be rigid. So these individuals, they feel very tense, right? They're going to be stooped over. They're also going to have this pill rolling movement. So if you look at their hands, it looks like they're rolling a little pill in their hand. So that's what it means when you have like a pill rolling movement. And so they're going to be shuffling around, right? And then they're going to be moving their fingers, like rolling, like it's rolling a pill. Resting tremor, that's another thing. The resting tremor actually goes away when they initiate movement. So they're going to be sitting here like this. So if you did like that, like hand to nose, the finger to nose thing, right? So they might be sitting like this, like resting tremor. Once you ask them to actually initiate movement, then it's actually going to smoothen out. So that's one of the things that you might see on a physical exam. If they have a resting tremor that goes away once they initiate movement, that could be Parkinsonism or Parkinson's disease. Dystonia, you're going to have weird facial expressions. You're going to have involuntary muscle spasms, especially in the face. Akathisia is just restlessness. Akathisia, one of my supervisors when I was doing psychiatry, he was involved in a study that was looking at haloperidol, which is that antipsychotic that I was talking about earlier. When he took haloperidol for that study, this is back in New York, he got really bad akathisia. He felt so restless that he spent the entire day and the entire night riding his bicycle from, the south side of Manhattan all the way up to like the Bronx and back. He was just riding his bicycle all across Manhattan just because of severe akathisia and restlessness. And that was a side effect from the drug. So if you see a person that's like super restless and they like keep on moving, they have like, maybe they're walking around a lot and they're like hyperkinetic, that could be akathisia. And then tardive dyskinesia, this is the one where they're protruding their tongues out. Looks really weird. So let's watch a little video of this. So lots of weird grimacing. This guy doesn't have the tongue movements, but all the grimacing. So that would be an example of like dystonia, tardive dyskinesia. Let's watch a video of chorea. Let me get a good video of tardive dyskinesia. I'll find a good video of that. Might be a good one. Let's see.
This video was sponsored in
Actually, here, this looks like a good one.
Tardive dyskinesia is characterized by involuntary repetitive movement of extremities, as well as grimacing, rapid blinking, and impaired movement of the fingers. There is no known treatment, and the symptoms are rarely reversible.
See how she's sticking her tongue out right there?
The symptoms may lessen or resolve when the drug is stopped.
So, dang it. That was a good video too. I need to put some good videos of tardive dyskinesia. But yeah, you'll see the person like protruding their tongues out. They'll do the whole grimacing thing. And then chorea, this is that dance-like movement that I was mentioning earlier. So they're going to be moving around a lot.
During the Middle Ages, and later to describe the abnormal gait and stance of patients with Sydenham's chorea. We now use the term chorea, however, to define a class of abnormal involuntary movements. Choreic or choreatic movements consist of individual, brief, purposeless, non-repetitive jerks of individual muscles. These tend to be rhythmic and non-patterned, but they appear in series or groups, which result in rather complex movements. The movements are made more complex by the patient's attempts to mask them by purposeful movements. Here we have a patient with fairly severe choreatic movements involving various parts of her entire body. Here you see movements involving the jaw, the tongue, the mouth, the neck. Each is an
So what's going on with her face, that would be tardive dyskinesia on top of all the abnormal choreatic type movements.
individual, brief, sudden, purposeless jerk. In this individual, the choreatic movements are due to Huntington's chorea. The individual movements, however, look the same no matter what the etiology of the choreatic disease.
Yeah, so absolutely horrible. Very sad. So, in other words, Parkinsonism, hypokinetic, Huntington's, hyperkinetic. So you're going to get a lot more movement. So here's another summary of Parkinson's versus Huntington's. So with Parkinson's disease, bradykinesia. So that's slow movement. So a person with, I never saw, this was like a story that was, the neurologist that was teaching at my medical school was telling me a story, or telling the class a story about a guy that he saw with Parkinsonism. They even have once they start walking, they have a hard time like shifting direction. And so he saw that this guy walking around with a shuffling gait. He had a cane with him, and then when he wanted to turn a corner, he took the cane out and like held on to a light pole so that he could pivot around the light pole because he had a hard time actually like turning. So these are the kinds of things you see with like bradykinesia. Difficulty initiating movement, and then even when you do start initiating the movement, sometimes it can be a little difficult to stop it. So yeah, all that stuff is happening simultaneously. So that's bradykinesia. Let's watch a little video on bradykinesia.
This is slowed movement, and here you can see the shuffling gait characteristic of PS. This gave rise to the term the Howell shuffle, as it is a common response to haloperidol in some people.
Thorazine shuffle. So let's watch that video again because look at his hands.
This gave rise to the term the Howell shuffle.
That's the pill rolling.
Common response to haloperidol.
So they'll be hunched over, they'll walk really slow, and then their hands are going to have that kind of like pill rolling phenomenon.
This shows a person immobilized standing, even though they've been asked to demonstrate walking. This is termed active movement, although one can see the characteristic pill rolling movement of thumb and index finger.
All right, so that's all what's going on with Parkinson's, and then with Huntington's, you're going to get hyperkinesia. So dyskinesia, you get tardive dyskinesia. Already showed you a video of that, but let's see. This one's a good one. Yeah, this is a good one. Watch his mouth. Lots of lip smacking. Yeah, there was this like tongue, like sticking his tongue out. You can get tics too, Tourette's type tics.
It's like a cough or a sneeze. It isn't contagious like some people think. A lot of people with Tourette's have different tics. My tics. He said I have to bend my neck and snap my fingers. But a lot of people don't even notice it.
And then cataplexy. This is a good one. Cataplexy. This is where literally you have a strong emotional response to something and you just pass out. It could be laughter. You could see something really funny and all of a sudden you like fall over. So that's cataplexy. Let's watch a video of this.
Wake up, Sleepy! No, I'm still filming.
She just throws the ball at her. It's so mean. Terrible, huh? It's kind of mean for them to be laughing at her and throwing a ball at her. It's so sad. So that's cataplexy. Let's look at hemibilismus.
Hemibilism is an involuntary movement disorder affecting one half of the body. Usually results from cerebrovascular accidents involving subthalamic nucleus, characterized by sudden flaring, intense, and violent movements. These movements are continuous.
I get the feeling that he's the narrator on that video. I think he actually is just demonstrating it. I don't think he actually has any Huntington's disease, but Anyway, so hemiballismus or hemiballism as well as be you can use either of those terms. So Parkinson's disease, I already showed you guys the pill rolling tremor, and then resting tremor, stooped posture, difficulty initiating movement, bradykinesia, shuffling gait. Look at this one over here. That's a fascinating gait. Oh yeah, not fun. Micrographia. Micrographia, small handwriting. It's also associated with sociopathy too. So if you see anybody or you know anybody that has really, really small handwriting, and if they don't have Parkinson's, they might be a sociopath. For whatever reason, micrographia is associated with sociopaths. I don't know why. So watch out for those people. Sometimes I'll get a student that I'll notice their handwriting is really small. I usually don't turn my back to them. Like, all right, you're probably a sociopath. Okay. All right, what's this one? Deep brain stimulation. This is one way you could treat Parkinsonism.
Both sides of the brain put in bilateral stimulator. The initial program discussion. What it looks like without the medicine stimulator. Now I'm just going to turn it on. I think button. There we go. Feel. Do I tap in both the fingers for them? All right. Feels pretty good?
So that's one way you could try to help with the symptoms. It's not going to cure it, but it's going to provide symptomatic relief. Same thing with these other drugs too. So carbidopa, levodopa, you're literally just replacing the dopamine. And I can't remember which one can't cross the blood-brain barrier. One of those can't cross the blood-brain barrier, so it needs to be used in combination with the other so they can cross the blood. I think levodopa is the one that crosses the blood-brain barrier, if I remember correctly. I don't remember off the top of my head, but you're basically just replacing dopamine. Someone raise their hand? Yeah. Yeah, I think it would help with everything. If you had deep brain stimulation, it would help provide relief for all those different. Yeah, that was deep brain stimulation. Yeah. It's like they put like a little probe into the brain. It's surgical, so they have a surgical implant. Yeah, yeah. So it's a medical device that they can use to stimulate parts of the brain. You can use deep brain stimulators for a lot of different conditions. Parkinson's is just one of them. I think so. I've never actually seen deep brain stimulators in person, so I don't know if they're always on or not. But you could look it up and see if they would probably have to keep it on all the time if they wanted to provide all the symptomatic relief. So, all right, here's a summary of everything you see, like the mask-like face. So it's blank expression, pill rolling tremors. You're stooped over. You got the shuffling gait. So those are all the things that you see with Parkinsonism. These are different drugs that can cause Parkinsonism. A lot of these drugs are your antipsychotics. So antipsychotics can cause them. Mood stabilizers can also cause Parkinsonism. So I'm not going to make you memorize all that stuff, so don't worry about that. Just know that some psych drugs can cause Parkinsonism. So let's talk a little bit about Huntington's. Any questions on Parkinson's disease? So know which pathways are involved. You're wiping out the substantia nigra, pars compacta. Pathway 1 is basically really getting wiped out, so you're going to get no initiation of movement. Huntington's disease, you get too much of the D2 pathway. Sorry, you get too much of the D1 pathway, you're wiping out the D2 pathway. So it's kind of opposite than Parkinson's disease. Woody Guthrie, really famous dude that suffered from Huntington's disease. Woody Guthrie is one of the most iconic American folk singers, songwriters. in history. And when he was getting into his 40s, he started developing Huntington's disease. And when you start developing Huntington's disease, it's terrifying not only for you, but it's also terrifying for your kids because it is autosomal dominant and your kids have a really high risk of developing Huntington's. And so they'll often, genetic testing would be a good way to at least, help clarify whether or not the offspring will get Huntington's. But even if you get, tested positive, there's been, I don't know if this is still controversial nowadays, but back when I was going to med school, it was kind of controversial because if you tell someone that they're going to get Huntington's disease at some point, that increases their risk of suicide like tremendously because it's kind of a death sentence when you tell a person that they're going to get Huntington's at some point. It's a horrible, horrible disease. I've seen it only once when I was doing my clinicals, and the poor guy, he was probably like in his 50s, and he was advanced stage Huntington's. He had to be like carried around by the people that worked at the hospital because he just was moving all over the place. Very combative too. Like if you have the coriform type movements, sometimes you can like hit people and stuff, so you have to always be kind of like restrained. It is irreversible and it is fatal. There's absolutely no treatment for Huntington's disease. Once you get it, that is it. It is very, very sad.
Woody Guthrie had complicated relationships with all of his children. His first three with Mary, Gwendolyn, Sue, and Bill, were loved, but also largely neglected by their father, and were left to be raised by Mary. On the other hand, Guthrie was extremely devoted to Kathy, Arlo, Laura, and Jody, the four children he had with Marjorie. Arlo went on to become a celebrated artist during the 1960s folk revival. Lorena, born on the cusp of Guthrie's long period of hospitalization and slow death, was all but forgotten. The mythic tragedy that seemed to dog Woody Guthrie throughout his life was carried down to some of his offspring, too. His son Bill died in an auto accident at the age of 23. His daughters Gwendolyn and Sue both died at age 41 from Huntington's disease. His daughter Kathy, whom he was closest to and nicknamed Stack of Bones, had died at age 4, sending him into a deep depression which Marjorie later believed had been the trigger for his Huntington's symptoms. Woody was only 42 when he entered the hospital for the last time in 1954. He would remain hospitalized with some brief breaks and transfers between hospitals until his death in 1967. The slow process of death brought on by Huntington's would be truly miserable for anyone. As it advances, the disease causes people to lose mobility, memory, and even the ability to speak and move. For Guthrie, the extremely prolific writer and singer who devoted his life to communicating with others through music and activism, this was a fate worse than death.
Woody has been in the hospital now for 10 years.
He and Marjorie had stayed in contact, having never truly fallen out of love. So as his condition worsened, she came back into his life to care for him until he died. Even with the diagnosis, the disease wasn't very well understood, and Woody Guthrie went essentially untreated.
Yeah, really sad story. So that's Woody Guthrie. His family put together the Huntington's Foundation, and so if you want more information about what they do, they like fund research and stuff for hopefully developing a cure for Huntington's disease. So we'll see if in the future that ever does pan out. That would be really wonderful because it is a horrible, horrible condition. So we already saw videos of Korea, but you're going to have all that repetitive type of movement. Let's see what this video looks like. Like dancing around, right? So you got uncontrollable movement. Athetosis. Kind of like a writhing type movement. And then hemiballismus, where you have half of your body moving around. The patient that I saw with Huntington's disease in the hospital, very similar to this, except the movements were even more violent. What's up? Um, so with Huntington's disease, family history would be really big. So on a test exam or exam question, you would see probably, dad had a movement disorder that eventually led to his death. And then now the son started to develop cortiform type movements, hemiballismus. So you would think right away, oh, this must be Huntington's disease because it carries a very strong genetic component to it. Right? It's a genetic disease. CAG, trinucleotide repeats, we'll talk about that in a second. That's going to be like the hallmark for Huntington's disease in terms of like the genetic changes. So family history is going to be huge. So remember that video I just showed you with Woody Guthrie? Like 2 of his daughters died of the same disease. They were talking about car crashes and stuff. That had nothing, I don't know what they're trying to get at with that. It's like, okay, his family definitely was like marked by a lot of tragedies. But the fact that both of his daughters died of Huntington's disease, huge, like genetic component, right? Arlo Guthrie, his son, dodged a bullet. Arlo Guthrie, if I remember correctly, is still alive to this day. Awesome singer, songwriter, super cool stuff. But he was, Woody Guthrie's son, terrified that he was going to get it too, but he didn't get it. So that would be one thing. Parkinson's, you would see a reduction in movement in general. So that hypokinesia, right? You would be able to, just by just hearing the description of the patient, you would be like, oh, that sounds like Parkinson's. Shuffling gait, right? Tardive dyskinesia, all those things would be like the pill rolling movement. Yeah, yeah. So yes and no. Yes and no. You when you see it, it'll be obvious when you see it on a test question. It'll be pretty obvious. Something like that, yeah. Or chloroform type movements, which are dancing type movements. So yeah. You'll see things like that on your vignette. What's up? Okay. Great question. No, it's not. Not so much. So sort of, because Huntington's usually presents once you get into your 40s or your early 50s. However, it gets worse every generation. Every single subsequent generation, they start getting the symptoms younger and younger and younger. So if dad had Huntington's when he started getting Huntington's at like 55, the son might develop Huntington's in his late 40s. His son or daughter, because it can happen to both sexes, his daughter or son might develop Huntington's at an earlier age than that. Because every single subsequent generation, they get an accumulation of those CAG trinucleotide repeats. And so let me actually just fast forward to that. These are the CAG trinucleotide repeats. The more of those CAG trinucleotide repeats you get, the more likely you are to develop Huntington's at an earlier age. And it increases as the generations continue on. So every single subsequent generation, you're going to see an accumulation of those CAG repeats. So if you have a lot of repeats, you're going to have more of a younger onset of symptoms. Versus fewer, it's going to be more of like an adult type onset of symptoms. So this is another reason why it's so scary, right? When you see like your parent getting Huntington's, you're like, oh shoot, I have a high likelihood of getting it, and I'm probably going to start developing symptoms even younger than my parents did. And so that's a really terrifying disorder. They must have. I haven't read any stories about Woody Guthrie's parents, but I would imagine that they probably had it. I don't know. I don't want to. Who knows? Maybe his dad died before he even developed symptoms. I don't know. I've never really looked into his family history so much. Be interesting to find out. There's probably some stuff online. Maybe you could look it up. Let me know. Yeah. Anyways, do you guys ever listen to Woody Guthrie? He's awesome. This land is your land. This land is my land. He was a communist, so a lot of his songs are kind of like commie songs. Same thing with Pete Seeger, his buddy. They actually, him and his all of his friends, they put together a band called the Weavers back in the 50s. During McCarthy, when they had the Red Scare and all that, the communist witch hunts, they actually blacklisted the Weavers. They blacklisted all of them, so they weren't allowed to like perform anywhere because they're all a bunch of like, pinko commies. So fun stuff. Communism. Oh my God. Anyways, I don't know what's worse, having Huntington's or being a communist. I'm just kidding. I used to be a commie once. When I was your guys' age, I was a card-carrying communist, and then I grew up. Anyways, what's going on with the neurotransmitters with Huntington's? So it's going to be involving the dopaminergic pathway a little bit, right? So you get some of that dopaminergic pathway. You get degeneration of GABA, so you don't have the inhibitory components. So if you don't have enough GABA, you're not going to be able to initiate movements much. It is genetic, right? So it's autosomal dominant. It's going to involve chromosome 4, and then CAG. Those trinucleotide CAG repeats are the ones that are the culprit. Symptoms. You start getting symptoms usually like in your 40s, and then by the time you get into your 50s, you die. So really sad. Death, pneumonia, right, because you're aspirating. So those are all. This video is interesting. Poor guy.
And it makes it hard for me to also kill me. He also thinks my brother has to change.
All right, you guys get the idea. Sad. Signs and symptoms, we already talked about a lot of these already, but extrapyramidal, right? So these are extrapyramidal type symptoms. You get those choreiform type movements, athetosis, chorioathetosis, so it's a combination of both of these. Right? So you're going to get all that writhing movement plus the dancing type movement. Over time, you start losing your cognitive faculties as well, so you start developing full-blown dementia. Bradyphrenia, which is slowing of your thoughts, loss of memory, and you can have either euphoria or depression or a combination of both. So, and then so if you want to do a radiographic study, you could do a CT or an MRI. It's very similar to what you would see in other neurodegenerative disorders. You'll see ventricular dilation, right? The ventricles are dilated. You'll also see atrophy taking place at the cerebral cortex, atrophy of the basal ganglia. If you were to do a genetic testing, which when a parent gets Huntington's, the kids usually want to know if they're going to have Huntington's too. It can help them like prepare for the future, right? So it does increase their risk of suicide, but at the same time, it's good to be informed. Some people don't want to know, right? Some people would prefer to be ignorant, right? Ignorance is bliss. Sometimes they don't want to know if they're actually going to get it. But if my parent had it, I would want to know if I, just so I could plan in advance what to do in my later years. So this is what the ventricles would look like. You have the widening of the ventricles. You see over here, the subarachnoid space is also pretty wide compared to normal. All right, any questions on the most depressing conditions in neurology? Those are all really depressing. So, anyways, all right, so that's all that. That's your dementias, and just be familiar with the pathways that are involved in each of those. So let's continue on. We're going to talk a little bit about multiple sclerosis. So in your central versus peripheral nervous system, you're going to have different types of cells. So you have neurons and glial cells, and glial cells basically act as ways to support the neurons. Neurons are going to be either myelinated or unmyelinated, right? If they're myelinated, that's going to involve the axon. The unmyelinated parts are going to be like the dendrites, as an example, the cell bodies. And if you're in the central nervous system versus peripheral nervous system, there's going to be different types of cells that that create the myelin sheath. If you're within the central nervous system, specifically oligodendrocytes, those are the ones that create the myelin sheath, central nervous system. Once you get to the peripheral nervous system, Schwann cells are going to be what create the myelin sheath. And you have to have myelin so that you can maintain the integrity of the signal, right? During depolarization, you want that signal to be sent all the way down to the end of the axon where you have either a synapse, right, where it's presynaptic terminal, postsynaptic terminal, from neuron to neuron, or the neuromuscular junction so that you can actually initiate skeletal muscle contractions. Multiple sclerosis is going to affect the myelin sheath, so you get demyelination, and it is specifically going to be affecting oligodendrocytes. So it's going to specifically affect the central nervous system. You're not going to see peripheral nervous system being directly involved. If it was the Schwann cells, then you would get peripheral nervous system. But it's oligodendrocytes. What's happening? It's inflammatory. So this is an autoimmune disorder. So autoimmune disorder, your B cell and T cell lymphocytes are creating antibodies against your own cells. B cells specifically. B cells are the ones that turn into plasma cells and create immunoglobulins. So they're going to be targeting and destroying oligodendrocytes. So you get both plaque formation and you get degeneration of the axons. Don't worry about the 4 major types, but remittent, relapsing, primary progressive, secondary progressive, progressive relapsing. I don't really care about those subcategories for the sake of this class. But this one is the most common where it happens. You get a MS attack. You get all the signs and symptoms, and then it gets better. And then like maybe a couple months down the road, maybe a year down the road, you get another MS attack. And then symptoms get worse and worse. So it's like you have periods where you have the attack, you have neurological symptoms, then it gets better again, and you're in remission. Then you have another attack, and then it just repeats itself. I had a friend of mine that had that. She would have like a MS attack, and then she would feel fine for a little while. And then it would happen again. So it would like progressively get worse and worse and worse. These other ones, though, they're more progressive, right? So it's going to be constant, right? It's going to be constantly getting worse and worse. Versus this one, you're going to have, it's like, it's happening in a stepwise fashion, right? Eventually it gets really bad, right? In its more advanced stages. So this is autoimmune. It could be involving like a virus, post-viral. It could be genetic, it could be deficiencies of vitamins. Family history. So there's a genetic component to it. So if you have a family history of MS, then your chances of getting MS are going to be greater. It is much more common in females than men. That's another thing to keep in mind about MS. So signs and symptoms. Visual changes are going to be some of the first things that you see because your eyes are going to be innervated by central nervous system, right? So it's going to be oligodendrocytes that are going to be affecting your cranial nerves 3, right? And so if your eyes are going to be affected, you're going to see inflammation. And then if you were to look at the optic nerve, cranial nerve 3, you're going to see demyelination of the optic nerve. You'll have painful eye movements. You might get vision loss. You might even experience blindness, right? Other things that might happen too, balance issues. You might have difficult maintaining balance, memory loss, weakness, fatigue, lack of coordination. Anything that's affecting the central nervous system and the signs and symptoms that are subsequent to that, you would see, right, with MS. Bowel dysfunction. Lermitsine. Lermitsine is a sensation of an electrical impulse going down your spine. So that is what lermitsine is. You feel like an electrical surge taking place. Paresthesias can also happen too. And if you were looking at the brain, you can see the little plaques. You can see the plaques which would be indicative of demyelination. So here's I believe that's an MRI, and it's showing the different areas of the brain that are being affected. All that plaque formation. So MRI is going to be a really good way to test for this, right? You'll be able to see those changes on MRI. And you can't cure it, but you can, again, slow down the progression of it. And so it's an inflammatory disorder, and so you can take anti-inflammatory drugs. So you can take Immunosuppressant drugs, you can take corticosteroids. Those can all help. You can also take drugs that block the ability for T cells to attack these regions of the brain, right? So any immunosuppressant drug, interferon beta could also help. Leteromir is another one. So here's a summary of all those different effects, right? So lermetsine, that's where you have that electrical feeling of like an electrical impulse or a surge taking place. Paresthesias are going to be common. Optic neuritis is going to be another common thing. Corticosteroids, interferons, and yeah, that's basically it. You're just going to slow down the progression. You're not going to cure it though. Incontinence, sexual dysfunction. Those are all side effects of MS as well. MS is a really, really nasty condition, and it is relatively common. I've known a few people that have had MS. So yeah, don't worry too much about the different subtypes of MS. I'm not super concerned about those for you guys. Here's one thing that really sucks. This is trigeminal neuralgia. We talked about cluster headaches, which are referred to as suicide headaches. Trigeminal neuralgia is another thing that can drive people to commit suicide. It is so insanely painful. It is like described as one of the most painful sensations you can have. And it happens to the face, right? Because of the trigeminal nerves are what provides sensory input to the face or from the face. One of the most like horrible things with MS is some of these patients can develop trigeminal neuralgia. So you have demyelination of the trigeminal nerve that can cause some severe pain. I've heard that even like a gust of wind can trigger trigeminal neuralgia in patients with this condition. So extremely painful. There are certain drugs you can take to help, right? So like gabapentin can help. Pregabalin can help. Those drugs really suck because they make you really tired and lethargic. So, and they don't always like totally address the the actual underlying issue. So some of these patients sometimes have to go into surgery to do a nerve ablation type surgery. So they'll actually go in there and literally sever the trigeminal nerve so they can prevent this from getting worse and worse. So pretty nasty condition, and can increase people's risk of suicide as well.
I am generally a very positive and happy person, but some days I can't tolerate it. First time I heard trigeminal neuralgia, I kind of did what everyone else did, and I kind of went, what's that? The trigeminal runs from the base of the skull all the way through the face. And basically what happens is the nerve misfires and causes extreme. It feels like somebody is taking a screwdriver, sticking it in my face, and then taking car battery chargers and connecting them and trying to turn them on. I don't know exactly what's going to happen, but
That was hilarious. Researchers are trying to find a cure by 2020. Yeah, I think the ship has sailed.
sometimes we have certain triggers for chewing or pushing a hair out of my face. So, and then some of us also have this searing, burning pain that's there 24/7 and never goes away. I'm lucky enough to have both. I think everybody experiences pain differently. So being able to teach a class, and I realize that there are people that are counting on me to help them achieve their goals, it helps me. Like it helps me live. Fitness, while I love it and never want to give it up, I have a fear that I'm not going to be able to teach forever because when it gets really painful, sometimes I can't do it, and I just don't want to give up what I love. I've been struggling with the disease for the last 7 years and hid it from everybody because I didn't want the disease to define who I was as a person. I was diagnosed with a very rare neurological I told everybody this summer because as it's progressed, I haven't been able to hide it as well. And I realized that getting this disease meant that like I was here for something different. That I was meant to get the word out so that people are recognizing, okay, this is a real disease. Glasses sitting on my nose causes
Sometimes looks like I stutter, but that is really me getting zapped as I talk.
Right now, for instance, I'm probably at 7. Most people would be lying down.
we need to find a cure. We need to spread awareness.
Thank you for watching. And I wish everyone angry days.
The data has over the last few seconds, almost 2 hours. But today, 100% of all patients will be going to the facial data research challenge.
We've already called this fundraiser our first annual, so our goal is to continue to have them every year. Ultimately, I would love it to be concurrent with an opportunity to coach or life coach people with confidence.
Thank you. That's strong.
So when I'm unable to teach it, hopefully won't be for a long time. I'll be able to sort of still do the things I love.
All right. Another really sad one. It's showing you guys all sorts of sad videos. So that was multiple sclerosis, which predisposes people to get trigeminal neuralgia. Any questions so far? We have a few minutes left. What's up? It never goes away. Once you have trigeminal neuralgia, that's it. You treat it symptomatically with those drugs that don't really do much, or you could do like a nerve ablation type surgery, but there's no real like cure for it. Yeah, well, if you had flare-ups too of multiple sclerosis, you have flare-ups, that means that your autoimmune, like destruction of the oligodendrocytes is getting worse and worse. Those would also be considered like flare-ups. So it could be symptomological, or it could just be like the underlying pathophysiology destroying the myelin sheaths of those cells. They can go in there and do an ablation surgery to remove it. So you'll no longer have sensation of the face. But I don't really know what the success rate is of those types of surgeries because, like phantom limb pain, right? You lose a limb, you're still going to kind of feel like your brain still perceives that pain. So I don't know if there's an equivalent to a trigeminal nerve ablation type surgery. There might be some sort of like residual pain. So I don't really know the full details, but I haven't looked into it enough to be able to tell. So let's talk very, very briefly about upper motor neurons and lower motor neurons because we're going to talk about ALS. And ALS, another really depressing one. So, but ALS is going to involve both upper motor and motor neurons. What's upper motor neurons? Brain and spinal cord. What's lower motor neurons? The nerve roots and then your peripheral nerves. So that's basically the main distinction between those two. If you have lesions of upper versus lower motor neurons, you're going to have different types of symptoms. So if a patient has a stroke and affects their upper motor neurons, you're going to see things like weakness, paralysis of the muscles, but you can also see things like hyperreflexia. So this is a Babinski sign. So if you were to do what you do is you take the bottom of your reflex hammer, the handle, and then you run it on like the outer edge of the patient's foot. And if they're normal, they're supposed to like curl their toes up. If it's abnormal and the toes fan out and up, that's indicative of an upper motor neuron lesion. So the patient could have had like a stroke, for example. So that's all upper motor neuron. And then lower motor neuron, you get a diminishing of all those things. So you also get weakness and paralysis, but you might see a weak, diminishing muscle tone. You might see absent reflexes. So if you did a patellar test in that patient, try to like hit the patella, you might not get any reaction whatsoever. Okay, so that would be lower motor neuron. So upper motor neuron, everything is like more excitable, right? So you have muscle tone is going to be increased, reflexes might be increased. Lower motor neuron is going to be the opposite. Everything is going to be diminished. The saddest thing I saw when I decided I never wanted to do neurology, aside from declaring brain death on a patient, was this one poor lady who had a stroke, and she was like in her like late 50s, early 60s, just like a total sweetheart. And I was sitting there talking to her, and she has to go to the hospital periodically to get those Botox injections. So the Botox injections help to loosen up the muscles, because even though she had a stroke, she can still feel it, and those muscle contractures are extremely painful. And so she has to get loosened up with Botox injections periodically. I was like, man, this is really sad. It was very, very difficult to see. We only have 2 minutes left, so let's continue with ALS next time we meet. And next time we meet, we'll also complete the whole section on psychiatric disorders. There's supposed to be a question on your exam next Friday on rheumatoid type disorders, rheumatism, things like that. I'm going to actually make that for the next exam, exam 3. So we're only going to focus on neuro next week before the exam. That's going to be it. So other than that, you guys have a wonderful weekend, and I'll see you on Wednesday.